On-the-scene coverage of AHA-13 is supported by Janssen Pharmaceuticals Incorporated.
I'm Peter Block, and I'm back, and we're back at AHA in Dallas at the annual meeting for On the Scene. With me is Tony DeMaria. Again, no introduction needed. Tony, well known to everybody. Tony, we're here to talk about the late-breaking clinical trials, many of which really didn't have particularly wonderful outcomes. But we have an interesting trial, TOPCAT.
TOPCAT, long-awaited trial, one that was anticipated by many individuals because we don't have good treatment for heart failure with preserved ejection fraction. And this trial, based upon the success of drugs like spironolactone in heart failure with reduced ejection fraction, then took spironolactone and tested it as an effective therapy in heart failure with preserved ejection fraction. Again, was a very well conducted trial, large, but the primary endpoint, which was a composite of 5 or 6 different events, including stroke and heart attack and heart failure, hospitalizations, et cetera, was no different. So spironolactone didn't help there, but it did reduce heart failure hospitalizations as an isolated secondary endpoint.
Well, you know, Tony, this whole business of restrictive cardiomyopathy and how to treat it has been a problem, and particularly since we had the ROUSE trial and the EPHSIS trial that showed us with congestive dilated cardiomyopathy, patients did so well with aldosterone inhibition, and now we all of a sudden have this negative trial. So what's your take? I mean, you take care of these patients. What are you going to do with this kind of aldosterone inhibition in patients with restrictive cardiomyopathy? Continue it, not continue? One of the problems in this trial was the potassium issue.
Sure. Right?
And any increase in potassium carried with it in a large population, of course, an increase in risk. So what's your thought?
Well, it's really interesting. As I say, there was a benefit in recurrent hospitalizations, and that was also found in an earlier trial with an angiotensin receptor blocker. But on the downside, there was both hyperkalemia and hypokalemia. I have no idea why that was. I think balancing it out, we just don't have good therapy for heart failure with preserved ejection fraction. It drives me nuts. I like to refer those patients out to someone else.
So while we're talking about heart failure, let's move on to another trial that actually specifically talked about the end-stage patient, ROSE trial, where there was an attempt to figure out whether or not naseritide or low-dose dobutamine made patients better that were in end-stage heart failure.
Yeah, and this was a group of patients with renal disease, and the concept was that these patients with chronic kidney failure might particularly benefit by these vasodilatory type drugs, naseritide and dopamine given at 2 milligrams per minute low dose. And again, Peter, the primary endpoints, which were an increase in urine flow or an improvement in renal function, were not significantly improved over usual therapy.
For all of us that have been giving low-dose dopamine for a long time, probably a waste of time.
At least in this group of patients with advanced acute decompensated heart failure and renal function, GFR less than 60, low-dose therapy didn't benefit.
All right, so let's go to, let's do something for the basic science guys out there, and progenitor or stem cells or bone marrow cells, call them what you will. 2 trials, TIME trial and GPAD-II. Tell me about TIME.
Well, TIME was actually a follow-up of a bone marrow cell study in patients who had end-stage heart failure. And what this particular analysis was a 1-year evaluation of infarct size and cardiac function as left ventricular ejection fraction. And in fact, what was found in these patients at the end of 1 year was that the bone marrow cells really did not make a difference, that there was a reduction in infarct size at about 6 months, an improvement in ejection fraction at about 6 months, but it was equivalent in these patients who received bone marrow cells to patients who did not.
So another sort of semi-negative trial for stem cells in acute coronary syndromes, I guess. Is that a fair way to say this?
When the initial data were presented, Dr. Rob Califf was quoted as saying it was not only negative, it was resoundingly negative. So this one, I would have to say, is really without a silver lining.
Well, let me give you a silver lining, the GPAD-II trial. The GPAD-II trial used GCSF. Low-dose GCSF, interestingly, because patients with high dose get sick and they have joint pains and it just hurts to get all those bone marrow cells out. Low dose for a long period of time, giving themselves the injection every other day. Short version was their white count did go up to 7 to 11,000 slowly over time. And this was a study of peripheral vascular disease to see whether or not patients could have a better 6-minute walk. And interestingly, they were able to walk longer, about a minute longer. I'm not totally impressed by how much more that's going to mean clinically, but I think there is a little bit of a silver lining in this trial. Finally, we have something that indicates that progenitor cells may do something to peripheral vascular disease. Any thoughts about what that mechanism might be? Do you think that this is neovascularization?
Well, I think it's almost certainly a paracrine effect. Whether it's increased growth hormone or some other angiogenic component, it's almost certainly paracrine. And it does, in a sense, lead to some optimism that maybe you don't, if you're using cell therapy, maybe you don't have to get those cells directly in the organ of interest to get a benefit. And that's a good thing. That'll stimulate further studies.
All right, so we'll leave you with a good thing for On the Scene in Dallas. I'm Peter Block.